Yes.
Email to me, you want me to provide some answers?
Yes, sir.
And write out the answers or come give you the answers?
Either one, if you wanna just, you've got my phone number,
Yeah.
or-
Cases.
well, and they're not,
Testing 1 2 1 2. Testing.
yeah.
Ready? Okay. Hi, I'm Frank Franklin. I'm a professor emeritus of public health at the University of Alabama in Birmingham. Today I'm going to talk about a subject that I think is terribly important, which is the integration of health care and population health. I'm using population health as synonymous with public health. The focus will be on COVID-19, and particularly between public health and healthcare delivery, that the need for good communication, cooperation, and collaboration. I've had a foot in both sides of that as both a physician, pediatric gastroenterologist, provided care to children for over 4 decades, as well as a degree and background in public health, and served as a chair of a department at our School of Public Health. It's a pleasure to talk to the entire Ascension hospital system. I can't really cover each individual state from Minnesota to Texas or Florida to New York. A lot of my focus will be on Alabama because I think the same situation is true in many states, particularly as we come into summer. Talking a lot about masks, so I have worn these masks. My Fruit of the Loom Ultimate Fabric Mask. We probably, if we have a fabric mask, probably need 3 layers. I just didn't have that many pair of Fruit of the Loom to use this. You'll get feedback for my presentation later in the hour, and sometimes the feedback might be that Frank, he's like a longhorn cow, a point here and a point there and a lot of bull in between. COVID-19 has had a vast impact on the healthcare delivery system in terms of basically shutting down elective procedures, a lot of outpatient clinic care, and then overwhelming ICUs with patients with severe pneumonia requiring respirators for the COVID-19 infection. We've also had a dramatic impact on the health of our population, with probably 130,000 deaths at this point of Americans, 500,000 globally, as well as the fact that we've had 2.5 million people develop this infection, so it has overwhelmed and killed our economy as well as the lives and livelihood of so many Americans. I want to respect and thank the scientists, doctors, and nurses and first responders, all of whom are on the front lines delivering care in many areas of the country. The hot spot right now is Houston, but it was in New York, and it will travel to other major cities throughout the U.S. I liken here a major healthcare problem like a ball, and it's best if we catch it basically with 2 hands, and that is the healthcare side and the public health side, and they really are complementary and not competitive. Give you a brief orientation to public health. It really is the science of preventing disease, prolonging life, and promoting health through organized efforts with large organizations, whether they be government or public and private organizations, and then ultimately individuals. To contrast public health with health care, the focus in public health is the population focus, whereas as physicians, where our focus is the individual patient care. Our ethic in medicine is to provide care the best that we can to the individual patient, whereas in public health, we are providing the best health that we can for the general public. That's the emphasis of public health compared to the emphasis in medicine, where we devote so much of our work to diagnosis and treatment. Clinical science is a major part of medical training appropriately, whereas it's more peripheral to the public health group. And public health is generally a government endeavor, whereas much of medicine is in the private sector. So we're really complementary. Public health has 3 core features. One is assessment, 2 is policy development, and 3 is assurance, to see that we have a competent workforce, but also that we evaluate what we do. So we monitor health. We'll focus a lot on that in terms of surveillance and testing. We attempt to develop policies, enforce laws, be they around tobacco particularly, assure that we develop a competent workforce, evaluate what we do, and do research along the way, as you're seeing going on during the COVID epidemic. As an example of prevention policies, we've had tobacco laws that have had major impacts, whether they be high levels of taxes, which has inhibited a lot of youth smoking, or they be food labeling, which we find very valuable in the supermarket, for instance. There are 4 steps that we'll go over, actually, in approaching a public health problem and converting it into a response. One is surveillance. Number 2 is, what is the risk factor? For instance, we define risk factors for cardiovascular disease, big cholesterol, high blood pressure, diabetes, obesity, etc. We do interventions. And then the question is, what works? And finally, the implementation. How can we do it at scale? You can look at the health impact pyramid that was developed by Tom Frieden when he was head of the CDC, going from its peak, where we do counseling and education, like tobacco warning labels and promoting quitting, in classic medical care, where we treat with medications, do cardiac caths, angioplasties, bypasses that we're all familiar with, preventive medicine with vaccinations, which I'll focus on extensively related to COVID, cholesterol screening. We try to make healthy decisions the default, like, for instance, seat belts and seatbelt laws, so that all cars have seat belts and they have warnings in there to put your seat belt on. Smoking restrictions in public places. We're in a hospital today, and it used to be, early in my career, where we smoked in hospitals. Now we can't smoke anywhere near a hospital campus. And then finally, what I spoke to you about in January, socioeconomic factors, including education and poverty reduction. So as you go down the pyramid, you're talking about, to the base, increasing public health impact. And as you go up the pyramid, we're talking about increasing individual effort and individual care. 10 great public health advances of the 20th century, just to focus on a few. One is, of course, vaccination. We've developed vaccinations against many of the childhood diseases that were epidemic when, for instance, I was a child. Part of the rite of passage was developing mumps or measles or German measles. And then, of course, the major one when I was a relatively young child was polio. Polio was a scourge in the U.S., and now we've almost wiped it out globally, except for a few areas in rural Pakistan. Motor vehicle safety. You know, we've dropped the number of accidents dramatically. Control of infectious diseases with sanitation and antibiotics. Big role for decline in deaths of coronary heart disease, and of course the recognition of tobacco. If you look at heart disease over the course of the 20th century, we had this massive increase, essentially a 100% increase in heart disease through the early 1960s when I was in medical school, to now lower than it was in 1900. We see a big drop-off in influenza and pneumonia. A lot of that was changing from living in tenements to more spaced out living. And we, of course, see the peak there, which was the pandemic of 1918. We've decreased accidents. Strokes are way down as a result of antihypertensives and some salt restriction. So we've seen that we've really addressed this major problem of heart disease, cardiovascular disease that is, and we've addressed it from 2 sides. We've addressed it from the medical side with ICUs and defibrillators and statins and angiotensin receptor blockers, et cetera. And then on the public health side with dietary changes and tobacco cessation. And you can see that the change in tobacco consumption, despite an increasing population, etc., was dramatic, so that it peaked in the 1960s and has essentially fallen off dramatically. And there's, for instance, all of us as physicians used to smoke back in the 60s, and you'll hardly see a physician who smokes any longer. Let's talk about the public health response to infectious diseases, particularly like to COVID. First and foremost, of course, is disease surveillance, which is where we look at the population and the rate of disease and spread. We need testing to do that. To control the disease, we need not just testing, but contact tracing. We will want vaccinations and drugs that will limit the problems with COVID, for instance, and some of an antiviral or an anti-inflammatory of sort. And then we have to plan for the next pandemic. This pandemic was expected. Bill Gates talked about it 5 years ago. We had a pandemic planning force that had a whole book on what to do in the White House, finished in 2017. So we were expecting this. And as Tony Fauci has talked about, a respiratory disease that arose from animals was entirely predictable. So surveillance is to identify the instances of disease in the community. So what's the rate? What's the incidence rate of new cases? Who gets it? How does it spread? And then we need to test people, and we need to trace and then isolate those cases, all as an effort to control the spread. This is a novel coronavirus. It appeared the last day of 2019 in Wuhan, China, where a good observing physician, actually an ophthalmologist who subsequently died of COVID, reported an excess of people with a new pneumonia. Even within 2 weeks, the Chinese had released the genetic sequence for this virus that allowed us to develop specific diagnostic tests. First case in the U.S. was someone who returned from China by January 21, so 3 weeks later. By the end of the month, we had seen human-to-human transmission within the U.S. But then it was another 5 or 6 weeks before the WHO declared it a pandemic. And I'll show you in a moment that was actually mid-March or third week in March by the time we decided to put stay-at-home orders in place in various states within the U.S., and even some states were very slow in coming on to that. We even were able to start testing a vaccine within 6 weeks or so of the original isolation of the viral genome. So very rapid progress from the point of view of vaccine development, and I'll detail that in a moment, but very slow appreciation of the extent and spread of disease in the United States. Why the two were so different was we had the science available for the vaccine development, and we did not have testing to say what the spread was in the U.S., and we're still paying a price for that. So you can see the different stay-at-home orders by the state that you're in. Here in the South, we were slow. We really came into effect as late as April 5th, when we knew this was spreading like wildfire early in March. And so we were really 2 to 3 weeks behind other states like California, Illinois, New Jersey, and even the territory of Puerto Rico, who locked down much earlier than we did. Let's talk about coronaviruses. They're not a novel virus. This COVID-19 is. They're common viruses, some of which, and it's because of the crown, essentially, and I'll show you that spike protein in a moment, are common viruses, some of which cause illness in people and others in animals. The most severe forms, the respiratory syndrome severe types, have essentially all emerged from animal reservoirs into people. The 2003 epidemic of SARS-1, and then the current coronavirus, which is really SARS-2. They cause upper respiratory infections, and it can spread, obviously, from person to person, as we've observed. And the impact depends on how transmissible it is, and then finally whether there's background immunity in the population. And the big challenge was the 330 million Americans were all susceptible. And even if you take out the 2.5 million people who have been confirmed cases, or, as is speculated, as many as 20 million who have had the disease, you still are left with essentially 310 million Americans who have not had the disease yet. So that's a dramatic pool of susceptibles. It's spread by respiratory droplets. So little spit bullets come out when we cough or we sneeze or we sing or we shout. And you can remember the action films that show that spread. So these are droplets that are carried through the air just a certain distance. And so they fall into the ground or onto a surface within 6 feet. So they're not the aerosol spray that we can sometimes see. But the aerosols probably do occur in some patient's room when we're up close intubating a patient. There's some evidence of aerosol spray there, but not in the general community. It's a classic respiratory infection that spreads to produce a bilateral pneumonia that can be overwhelming, requiring ICU care, ventilator support, and a fair rate of deaths when patients arrive at the ICU. Yet many patients, as is oftentimes true, have mild symptoms or are totally asymptomatic. The incubation period is about 5 days on average, and symptoms appear 2 to 14 days after the exposure. The infection fatality rate is something that's discussed and argued about. It probably is in the range of about 0.5% to 1%. The reason why it's argued about is because it's a very difficult statistic to obtain. Why is that true? Well, the deaths are relatively easy to count because most of them occur in hospital. But they reflect what was going on in the population about 3 weeks earlier. And because and that's the denominator, is the number of people who were infected, the numerator is the number of people who die. It's very hard to get the denominator because we're not doing general population surveillance, and we don't know the number of people who were actually infected. Some evidence from cruise ships, aircraft carriers, naval aircraft carriers, suggests that it probably is in the range of about 1%. And it depends on the age and illness rate in your general population. We test with a nasopharyngeal swab, and to look here at the time course, essentially. The virus is isolatable from the respiratory tract for a week before to about a week afterwards. We can test for the presence of the RNA with a PCR test. If we do just a nasopharyngeal swab, it falls off a little bit earlier, but still is there by 3 or 4 weeks. And if we did a bronchoalveolar lavage, it's longer. But at the point where the PCR is falling off to tell us about acute infection, we're starting to see antibodies rise, particularly as we do with most infections, IgM first and then IgG longer. So that's the basis of serology. There's confusion about serology, but the other day, where they aggregated 14 studies, a group came to the conclusion that antibody tests are okay for serosurveys. Like the CDC just did one where they said as many as 20 million people in the United States have had the infection. They are not useful for guiding individual patients. And they're no benefit if we want to say, oh, you've had the infection and you want to come back to work, because they basically have high rates of of false positives and false negatives. And of course, if they assure you that you've been protected and then you come back into the workplace having been exposed subsequently, you will transmit the virus. So we can't use them to guide individual patients at this point. Let's talk about the viral pathogenesis and vaccine development and some aspects of treatment. The virus characteristic, the corona on it, is the spike protein that you see here in the panel. That spike protein is how it binds to our cells in the nasopharynx, the lungs, and also sometimes in other tissues like the gastrointestinal tract. It binds to ACE2 receptors. To essentially enter the cell, you need to clip off part of the spike protein, which then allows fusion proteins to blend with the cell membrane, where it gets taken up into the cell and then can replicate. Almost all vaccines are against that receptor binding domain, which is where the spike protein is located. Once it gets into the cells, it hijacks the translation apparatus to produce more of the viral RNA. And this is a very large viral RNA. And then it can produce proteins and more RNA, reassemble viruses, now large numbers of them, which are then spewed out of the cell to infect other cells and ultimately be spewed into the air. Our immune response is really bimodal. We have a cell-mediated response, and we have an antibody-mediated response. Essentially, the viral virus is presented to an antigen-presenting cell, which works with a T helper cell to recruit B cells, which then produce an anti-coronavirus antibody, and then they also recruit T cells and a cytotoxic T cell, which can kill the virus. So both mechanisms are active for memory, both the B and T cell. And so the body does react and generate cells that produce antibodies and cells that kill the virus, as we do with many viral infections. Let's talk about the types of vaccines. There are probably 180 vaccines that are being produced around the world. I'm going to focus on 4 types that are being funded by the U.S. government. The U.S. government has put out $2.3 billion to 5 or 6 companies to develop vaccines, and then the winners will go into major scale production, as much as $700 million, to produce essentially billions, literally billions of vaccine doses, and you can imagine the logistics involved in this, for all the people in the world. And so one of the first vaccines is one that's been developed by, or being developed by AstraZeneca and Johnson & Johnson, where they use a common adenovirus as a vector. And into that genome of the adenovirus, they put the coronavirus spike protein gene. So that relatively harmless virus, which we've used for gene transduction for many years, gets taken up into the body, and then, of course, it starts producing, not virus, but it starts producing an immune response to the spike protein. So that's being tested, and it's expected that trials, phase 3 trials, the real big trials that we'll need to demonstrate safety and efficacy, will start projected in August and September this year. The second main kind of virus being produced is an RNA virus being produced, an RNA vaccine being produced by Moderna and Tony Fauci's institute, the National Institute of Allergy and Infectious Diseases. That company is taking a RNA piece and then encapsulating it in a lipid coat, just like the virus itself is, and getting that taken up then into the cell, and then it produces, again, antibodies against the spike protein. So that's an RNA vaccine. The next kind is where we just basically inject the spike protein. And there are 2 companies developing that, Novavax and Sanofi. But it's slower in production. We give it as a nanoparticle with an adjuvant, like we use in many vaccines to produce a hyperimmune response. and whether they may begin trials by December. So that's where we just inject the spike protein itself. So the government has put out $2.3 billion, $700 million going to companies that will really produce this big-time scale. Let's talk about an antiviral, which has gotten a lot of press from Gilead, called remdesivir. It was actually developed and widely used within the antiviral vaccine network that Richard Whitley heads here at UAB as a prominent antiviral expert. It's being used in the first trial. Remdesivir essentially is a molecule that, when activated in the body, comes to look like one of the bases in RNA, and that is adenine. And so it essentially binds to the replicating enzyme, the RNA polymerase, RNA-dependent RNA polymerase, so that it stops the translation of the virus. And therefore, it just stops it in place, and you no longer have viral DNA, or viral RNA production. So it's effective, it looks to be effective, did not in a very early trial limit mortality. So it's being widely used, and yesterday Gilead put a price on it. The price for the US government is about $3,000 for a 3 to 5 day course. So it's a very expensive medication, and it will be certainly widely used. An old therapy that's 100 years old is the therapy with convalescent plasma. That started during the 1918 epidemic or pandemic with the flu virus. Right now, plasma from one person can be used for 2 to 3 patients, so that's sort of limiting, and it has to be isolated. The future is the production of monoclonal antibodies produced in the lab, which can be produced in large quantities, and that's on the horizon. One of the main techniques that's been used to control this epidemic has been modeling, which is a relatively newer technique. And I want to talk about determinants of epidemic spread. It really is so-called DOTS. The duration, opportunities, transmission probability, and susceptibility are equal to the R. So what are these things? Well, the R is the reproductive number, which simply is the number of patients that a given patient will infect. So one person, if he infects 2 persons, then we have transmission, and it will just go exponentially up. If it's 1 person or less, then the epidemic will ultimately die down. The duration of infectiousness is important. If it were very short, well, then we don't have as many people infected. The problem with COVID-19 is that it's infectious over 2 weeks. The opportunity is the number of people we contact, and so that was what we essentially did with social distancing by decreasing the number of contacts we had. The transmission probability is how infectious is it if we're within 2 or 3 feet of a person, we're not wearing a mask, how transmissible is it? Now, one of the things that's come out very recently is that the American and European version of the COVID-19 is much more transmissible, 10 times as transmissible, as the Asian form. It seems like there's been a mutation, so the spike protein is more stable in the EU and American version of the virus. It's not more pathological from the point of view of killing more people or making people sicker. It's just that any given occasion, whereas it might have taken 1,000 particles before, would now just take 100 particles to infect somebody. So that is a concern, and may account for the rapid spread we're seeing in the US. And then the susceptibility, which is what's the chance a contact will develop the infection? Well, that depends on our immune status. So herd immunity ideally would be produced by vaccines, and the vaccines, to be effective for this, since it's a reasonably transmissible agent, will have to be 70% of the population will have to be impacted or protected. So medications to shorten the duration, social distancing, stopping the transmission with masks and gloves and hand washing, and then vaccines. So my wife, as you can see from my hair, it's gone a little bit wild over the last 3 or 4 months, projected what it will look like if I go another 4 or 6 months. I'll develop this true bush, which I'm on the way. So let's talk about linear versus exponential growth. It's a concept that some people have struggled with because we're not used to thinking about exponential growth. So just to show you how rapid exponential growth can be, if we start with, essentially just a few cases, and it's growing every 3 days, doubling, and that's the blue line here. And the vertical axis is log units. So it's going to go by 7 durations, by 7 cycles, that is, or 8 cycles really. Through 24 days, we're going to go from a few cases to 1 million cases. That's logarithmic or exponential growth. We didn't appreciate that early on, and it's sort of strange because we're used to thinking 1, 2, 3. We're not used to thinking of 1, 2, 4, 8, etc. So the bottom line is that even 1 day makes a difference in how we shut down states. And that is that, for instance, you shut it down on day 20 versus day 21 of when you appreciate what's going on. That 1 day difference leads to a 40% difference in the number of cases one will see. And that's why states that shut down late were particularly impacted. For instance, in New York, Mayor de Blasio was suggesting that people still go out and party and visit the restaurants and bars, etc., when it was very clear that transmission was going on. We project, and there's an Institute of Health Metrics and Evaluation at the University of Washington, which has been in this business for a long time, and they've projected what the number of deaths will be, and I'll come back on that. But right now we're at about 130,000 deaths, and by October 1st they're projecting we'll have 180,000 deaths. Epidemic models are limited, as are all models, basically. They're limited by the assumptions that we use, and they're limited by the quality and quantity of the available data. So the more data we have, and we tighten up the assumptions as the IHME has done, is the projections then have a more narrow range of uncertainty. So they're not promises, they're just tools to guide public policy. And a prominent statistician summarized it when he said, all models are wrong, but some are useful. And I think these models have been useful. Let's talk about prevention with hand washing, masks, and distancing. There's no doubt the COVID-19 threat is real, but it's also manageable, as we were able to do with our lockdown procedures. Successful infection takes exposure to the virus and then the duration. We want physical distancing, as I've mentioned. We want to limit the length of exposure to 15 or 30 minutes or less. We want it done with masks, hand washing, or gloves. We want to avoid viral explosions, coughs, sneezes, and singing and shouting. And that's why it was so concerning that in our state and in our county, here in Jefferson County, they allowed churches to not participate in the mandated masks. And certainly one of the prominent part of all Birmingham churches is choir music, and we can expect that many members of the choir, unless they were wearing masks, will transmit the virus. And then we need to pursue people who are infectious, and that is the widespread testing, contact tracing, and isolation. So test, trace, and isolate. Many mechanisms or many protections are out there. The best protection, I think, is coming from a combination of face masks, particularly for the lay public. In hospitals, though, the combination of hand washing, gloves, face mask, gowns, as was done in a previous viral epidemic, prevented 91% of the infection. So they're very effective if we follow this personal protective equipment practices in hospitals. So we wash our hands for 20 seconds or more. There's never been as much happy birthday sung in the U.S. on every day as there has been during this epidemic. We avoid touching our eyes, nose, and mouth. It's one of the challenges of masks is that, and why face shields are particularly effective in hospital, because they keep it out of our eyes. We stay 6 feet distance, and then we wear masks. Early on, we had some confused messaging about masks, about whether they were effective, and then the whole idea that we were short of personal protective equipment. But recently, the IHME did a meta-analysis where they showed that if medical masks are used by the general population, there's a 45% reduction in the risk of COVID-19. And even the cloth masks, as used by the general public, the bandanas of the world, etc., reduce transmission by 33%. So I think the case is solid that mask wearing is beneficial. And in my view, should be mandated. I think wear a mask, yes, always wear a mask. If 95% of the population were to use a mask every time they would go out, we would stop the transmission of this disease. We'd knock it down, the transmission, by 50% or more. That's dramatic. The R would fall to under 1, and the epidemic would essentially peter out. And in many cases, mask wearing is so effective, that is, you know, if we use a good quality mask, that essentially it's as good as a vaccine. So I want to show you the difference in what happens if you project the use of masks and you don't. So starting just yesterday, we would expect that without masks and the rate of current easing in mandates to stay at home, open businesses, bars, restaurants, beaches, etc., that we'll see 180,000 deaths among Americans by October the 1st. If we were to wear masks, universal masks, 95% of people wearing masks all the time when they went out, that'll drop by 35,000. So essentially that extra 60,000 drops to about 25,000 deaths over the period of just the next months through October 1. So there was a big run on toilet paper for a long time. So I decided to rest on a supermarket toilet paper rack, waiting for them to restock the shelves. Let's talk about non-pharmaceutical intervention, particularly the lockdowns, etc. That one of the challenges with COVID is there's this long period of infectiousness, of, as I said, about 14 days. One of the challenges is that before symptoms occur, during this incubation period, you're infectious. And so we can't really wait for a case to develop symptoms because they've already transmitted a fair amount of the infection. And so that's one of the problems. That delay is why it's so difficult and why we probably need more general surveillance of the population and not just symptomatic individuals. We've been effective at squashing the curve, or so-called flattening the curve. And that leads us to potentially a long tail of the curve, the first wave, or even maybe a second wave. Some people have likened it to a cat. So the real acute wave would be like the alert kitty, will pounce and shred the healthcare system. That's what we were trying to prevent, is overwhelming ICUs, like sometimes cats do to the arm of your couch or your drapes. Or you can have the lazy kitty, which is stretched out over intervals, and it slows transmission events, and the healthcare system can cope. That's why we went with the lazy kitty approach. These are difficult things to balance. We had to balance health with socioeconomic consequences. And by being low and slow in what we did, we paid a price on both fronts, in that we have 130,000 people who have died, 2.5 million people who were sick, and we have 40 million people unemployed. We have almost a $6 trillion debt as a result of the appropriate measures that were taken to prevent people from losing paychecks. We've had social disruption. We've had fear, panic, and we've had a burden on parents of the school and the attempts to educate children at home. So the crisis, there's been challenges of communication. And I think you can go over these in the notes, but essentially we've done a poor job by essentially having non-scientists communicate. We don't have a messenger who is perceived as honest, credible, competent, expert, dedicated, committed, and understanding and empathetic. We have to give a single overriding health communication objective in any communication, so a so-called SACO. So we have to identify and explain the public health threat, say what's known, explain clearly and plainly what's going on, but get one main message across rather than a whole series of confusing messages. And our healthcare and our leaders have to essentially model appropriate practices. So the person who speaks has to be truthful and accurate, informed and current. They have to know their audience. They have to beware of minefields because the news will extract single bits of information. So if you're asked a question and you don't know the answer, you say, I don't know, but I'll do what I can to find out. And you have to be willing to put a line in the sand and quit or be fired. And that is our top responsibility as a physician is our patient, and a public official's responsibility is to the people. So the words have to be delivered responsibly, carefully, professionally. And that's one of the most important public health tools. There's always uncertainty about this epidemic or any epidemic. And so we have to let people understand the uncertainty and what we're doing to find out the answers. And that may take additional research. And only fools are certain of themselves, while wiser people are full of doubts. And so we do have hesitancies. There's been crazy crap out there, mythologies. I mean, so some people thought, well, you got it from Corona beer, and it probably killed the Cinco de Mayo. If closing the bars and everything didn't kill Cinco de Mayo, some of the fears around Corona beer probably did. And then some people believed it had something to do with 5G towers, one of the newer transmission mechanisms for our phones, etc. And of course, it has nothing to do with that. And we've well appreciated that coincidence and correlation are not evidence of causation, except in the minds of some conspiracy theorists. We've had a series of failures and flaws, and we fooled ourselves. And as I pointed out, early action could have prevented both the loss of lives and livelihoods. And there will be a 9/11 commission, type commission, impaneled to look at some of the failures that we've had. We had the opportunity to learn lessons from Hong Kong, Singapore, Japan, and South Korea. These are all open democracies in various ways. I mean, Hong Kong is coming back more under tight Chinese control, but certainly Singapore, Japan, South Korea. They were very effective in combating the trend, in combating this epidemic. They were all geared up from the SARS experience in 2003. Let's just compare the United States deaths to the deaths in the EU. The EU actually has a larger population, about 440 million people, compared to our 330 million people. What you see is that it peaked in the EU a little bit before it did in the US, and that was Italy and Spain, and we heard a lot about that. But then it's dying off. Whereas the US has peaked, started to have a plateau and a small decline, and now, more recently, in the last couple of weeks, we're seeing an increase through June 26th. So yeah, we've done a poor job of controlling it. When we started to have it under control, we gave up. So what are some of the failures? Well, we were unprepared for the pandemic, despite the fact that we had a book right there in the White House. Then our response, unfortunately, mask wearing, has gotten mixed with partisanship, politics, and a whole bunch of unfortunate stuff. We've had confused and uncoordinated leadership at the federal, state, and city level. So the ball has been pushed down and handed off to the states and then the counties, and everybody's making their individual decisions, when we had the opportunity to provide more informed guidance from the feds. The CDC, our prominent public health organization, was weakened by their early experience with the test and then constrained. So essentially they've been missing in action. We've had the flaws in communication that I suggested. We had this foolish and false sort of separation of economic and population health. Like you can't have one, or you can only have one and not the other. Clearly wrong. We've had lack of personal protective equipment in hospitals. Our failure to protect healthcare workers. That's unforgivable when we had the opportunity to produce so many masks and we had so many in storage. And then finally, we've opened states, ignored CDC guidelines, and we haven't had strong test, trace, and isolation capacities set up. And we're going to do that continuing with bars, restaurants, schools, universities, businesses. So it's fairly easy to predict what's going to happen. The CDC has had a flat budget for a decade. Public health has lost 24%. State public health departments have lost 24% of their revenues or income. Whereas healthcare spending grew by 52% in the past decade. And so we've limited public health, which was always like 3 to 5% of the total healthcare budget, and we've knocked it even further down. So it's not surprising that we're not able to address this pandemic. Will we do better with the next pandemic? I certainly hope so. So we had the guidelines for opening up America. The challenge is we didn't follow them. The idea is for epidemic control, you need to collect evidence of the epidemic control in your own locality. We needed to continue surveillance, which is really testing as we gradually open sites. If we're going to reopen schools and workplaces, we can do that with expanded online capacity, and we have advisory groups. And then we need to work to fully restore financial and social health and preparedness going forward. Alabama, as most southern states, was poorly prepared to open, to suppress disease and prevent a full-scale epidemic second wave, and we're probably still riding on the crest of the first wave. It is not additional testing that's reflected in the surge in cases. It's genuine cases. Fortunately, deaths have decreased slightly in the last couple of weeks. That's testimony to excellent medical care and the shared practices, best practices that have gone on between hospitals and ICU providers and potentially convalescent plasma and remdesivir. So yeah, we've had a lot of changes that have improved medical practice and over even the last couple of months. So the deaths, fortunately, are dropping. Also, more of the infections are younger people who have a lower infection fatality rate. Testing is still low in many places. Contact tracing is almost absent. And we did not demonstrate a decrease in cases 14 days before we opened up. We didn't ramp up test capacity, and we didn't ramp up contact tracing. And so when you're behind 40 points coming into the last quarter, chances are you're not going to pull it out. So failure to test and track adequately assures disease spread, and that's true of so many states. But what metrics do we manage? And those are the ones we pay attention to. Well, the COVID case growth. So are cases increasing, stabilizing, or decreasing? What's our testing capacity? What's our capacity for contact tracing? What's our ICU safety margin, just like it's getting overwhelmed now in Houston? So we need the data to drive better decisions. Do we have that data in many places? Simply no. I won't bother to review the infection rate, the R, which is still above 1 in Alabama, which means it's being actively transmitted. Our testing capacity is low. Contact tracing is absent. and we're starting to fill ICU beds. So what's the future going forward? Well, I must admit that I'm not terribly optimistic about our control. COVID-19 continues and will continue in new hotspots in the U.S., as I mentioned. By any test and surveillance mechanism, 90% or more of the American public is still susceptible. I expect there will be intermittent and local shutdowns of schools and businesses. In the fall, we're likely to have another influenza epidemic. So we're going to have 2 respiratory pathogens active in the population at the same time. We can expect sort of both synergistic impact and a greater number of deaths. So it'll be important for everybody to get their flu vaccine. The relief, which has made a difference to so many of the people in the U.S., in terms of rent and in terms of jobs and job security and payments and paychecks, things that are so critical for so many people, has gotten politicized. So as in March, we acted quickly and effectively. Now we're arguing in Congress what's it's going to do to the national debt, et cetera. We've got the national election coming up November the 3rd, and I think people are going to get out there and vote, or get out there and send in ballots one way or another. But we're seeing intense rancor and anger in the U.S. We saw that with some of the protests lately, but we're going to see, I expect, a lot more of that over the next several months. How to avoid being overwhelmed by the news and views? I think, well, I've given you some websites here with Johns Hopkins, COVID Action Now. Every state has a group like Alabama Political Reporter, and then the projections from the IHME, the Institute for Health Metrics and Evaluation. As I see it, the beast of hatred is roaming our lands. Going back to Proverbs, there are those whose teeth are swords, whose teeth are knives, to devour the poor from off the earth and the needy from among mortals. And yes, that is continuing. In this panel from Art Hazelwood from 2008, at the recession at that time, we're seeing all of this rancor and anger. So, it's been a pleasure to speak with you. You'll get a chance to submit questions, and I'll be happy to attempt to answer those. Unfortunately, in this format, we can't address your questions live, which would have made it even more fun. But I'll try to answer them after the fact. And if I answer them with, I don't know, I'll look it up. Well, at least when I'm home, I'll have a chance to look it up or tell us how we can do a research study to answer that question. But I would hope you've learned something about how public health and healthcare delivery are integrated, how we were able to flatten the curve, for instance, how medical care has decreased the number of deaths, how we were able to decrease the number of cases. We probably would have had millions of cases, and instead of 130,000 deaths at this point, we would have had well over 1 million deaths. How new agents are coming along, how vaccines will come, although they may be another 12 months. I think the challenge is we need to be able to work to go into an area where there's active disease transmission and look in large-scale studies at both the efficacy of the vaccine in terms of preventing transmission and the safety of the vaccine. Well, thank you very much.
All right. Well, good afternoon. I'm Monica Baskin and a professor over preventive medicine at UAB, and delighted to be with you virtually for this presentation today, talking about understanding and addressing unconscious bias in healthcare. So a great deal of what I'm going to talk to you about today is part of an ongoing training program by Cook-Ross program, and they have a number of training modules around this particular topic. So I thought we'd start off with an example here. This is a commercial that unfortunately in our new day of virtual conferencing you won't be able to hear. We will have the link to this particular commercial in the live streaming that'll be on the website. But in general, this is a commercial that talks about or showcases some of the bias that might exist in certain kinds of corporate environments. So it's going to tell you or walk you through a scenario where there's a boardroom of sorts. There are lots of people around the boardroom, primarily men, some with ties, some without. And the person that you see here with his hands raised, with different hand signals there, is going to speak both at the beginning and at the end. And so I really encourage you to take a look at that later on. But what it showcases is that someone speaks and gives an idea, but then no one really pays attention to it, to the person at the very end of that table. The person wearing the jacket actually speaks that again. So what I found in doing this training over and over, I usually ask people to think about, have you been in a scenario like this before, where you said something or you observed somebody else saying something, and then only later on in the discussion someone else says the exact same thing, and they get a response from that. Oftentimes when that happens, the person who first gave the idea may be someone who is either female or they may be young. They may not be perceived as being a leader, as opposed to the person that you can see here, the gentleman with the tie and the jacket, who is perceived to be the leader, the person that you pay attention to. Some of the things that people say about the reasons why he might have been attended to more than the other person who made the same idea was that he looks to be the boss, the person in charge. He's actually sitting at the head of the table, which is another cue sometimes for that. And because of his hand gestures that he's using here, that may also give a clue as to who should be leading. But that scenario, oftentimes, what I'll say at the very end is I've certainly been a part of scenarios like that. I've heard a lot from the faculty that I work with at UAB that bring up examples like this all the time. It's not intentional, but it happens over and over again. And so the next video that, again, will be available online for you to watch at your leisure is one that really identifies this issue that we all have selective attention. There's so many things in our environment at any one given time, but we can't possibly attend to those at once. So this is a fairly short video, I think probably no more than about 3 minutes or so. And for those of you who are of a certain age, you might remember sort of Clue or these different kind of mystery different shows that are on, so that throughout the show you be trying to figure out who killed that person. So it's called Who Done It. In the screen that you can see here, there's someone lying on a rug. A gentleman is lying there. There's a object, a clock or so, that's laying next to his head. And then you have, 3 individuals who are considered to be suspects in this particular murder. Then you have sort of a constable or police officer, if you will, that's overseeing this particular case. And then you have the gentleman in the long coat with the hat, who is sort of the detective, trying to figure out who done it. So over the course of this video, there are a number of things that end up happening and changing. So I would, again, encourage you to watch it and look at it to see if you see those things changing. But as a cheat sheet, one of the things that you can see here is that this is the original frame that you see at the beginning of the video. But actually, there are a number of things that end up changing over the course of a couple of minutes. It's at a blink of an eye. So I guarantee you that you will probably not see very many of those changes. You certainly wouldn't recognize all 21 that end up happening there. But over that course of time, those things happen because we have selective attention. So they were able to masterfully change up who was lying there on the floor as the person who was being murdered. What was a bear in the top photograph was now, an armored statue in the bottom. The coat of the detective is different. What's on the table, sort of the vase is different, the color of the flowers, and so on and so forth. Again, just highlighting the fact that things can change in a blink of an eye, and if we're not really intentionally looking for things, we may miss them. And so I think, for the most part, it's those two examples are to really hit home that it's not a matter of do we have a bias or do I have a bias. It's really making sure that we understand that there are a number of biases that all of us have. And so sometimes when I've done this particular talk or have conversations about bias, we always come down to, what are you really talking about? So what is it? And is it something that we have total control over or not? So the other question that comes up is, why is this really important? So why was this selected as a topic for continuing education today? And why is it relevant to generally in the workplace, but also to healthcare more specifically for this audience? So I will attempt to answer some of those questions for you. So first of all, I think this is important for us to look at because we know that there are a considerable number of health disparities that exist. So for example, people of color typically receive fewer or less breast cancer screenings, kidney transplants, eye exams. They get less cardiac procedures, fewer vaccinations, less cardiac care, less cancer pain medications, and also they tend to get less mental health treatment. So all of these things are considered to be health disparities, and they are quite taxing to just personal lives in terms of mortality and morbidity, but they're also quite costly to our healthcare system. So those significant disparities that are translated to differences in treatment include disparities in diabetes, cancer, hypertension and high blood pressure or other cardiac conditions, kidney disease, stroke, addictions, as well as, again, mental health, depression, anxiety, and so forth. So we know that differences in treatment oftentimes will lead to differences in our outcomes as well. So here are a couple of examples of some published studies that try to tease out, what's happening here and how bias might play a role in our treatment. So this is an older study, but it was published in the New England Journal of Medicine, where they looked at the effect of race and sex on physicians' recommendations for cardiac catheterization. So overall, what they did was they showed different cardiologists different types of vignettes, and the vignettes in themselves were the same. The only thing that varied was the picture that was associated with the patient. So sometimes the picture was of someone who was African American or Black, and sometimes the picture was someone who was white. Other times the picture was someone who was male versus female. So they varied all those different scenarios, but the actual procedures and the history, the medical history and the exams were always the same. So what they found was that men and whites were significantly more likely to be referred than women and blacks to receive cardiac catheterization. So again, everything being equal, there's no differences there. There was a tendency to recommend those cardiac catheterizations for women and for individuals, there was a tendency not to recommend those for women or for individuals who identified as Black. Another set of studies have looked at, what is the role of diversity and inclusion, and have really come down and said that having diversity and inclusion really is important for innovation and productivity. So several studies by the Catalyst Group show that companies that achieve diversity in their management and on their corporate boards attain better financial results on average than other companies. So again, having greater diversity has not only benefits for trying to improve or reduce health disparities, but it also can improve your bottom line. Another set of studies have looked at, what can you do to actually reduce bias? And so raising awareness is one of the things that has been shown to improve efforts to reduce bias. So workshops and learning from medical professionals that focus on the science and research of bias can actually reduce its impact. And it's not that just having that knowledge on its own is going to do the trick, but making sure that that knowledge is being applied and that there's some action steps that you can take to help mitigate that bias. And we'll talk more about what those could be later on. So just want to move into the mechanics. So we've talked about, the fact that this may be important and why it may be important, especially in healthcare. We've talked generally about the idea that the bias does exist and it seems to be related to different health outcomes. But let's specifically dive into what is unconscious bias. So bias in itself is just a tendency or inclination that results in judgment without question. So it's kind of, very much automatic. It just happens. It's a response. You don't take a whole lot of time to sort of think about it and process it. It is really a shortcut to interact with our world. So you can probably imagine, just thinking developmentally, how this type of a shortcut could be very, very helpful. So most of us remember in some basic science class, we were taught about this fight or flight response. So if a saber-toothed tiger is coming at you, you really don't want to take a look and really take a lot of time to think through, okay, well, what's the size of this animal? Is it a friendly animal? Really, how fast do I have to be running in order to run away from it? That's really not practical in that sense. And sort of a life-saving trick is to basically just be able to see you're outmatched and you need to get away from that. But unfortunately, our brains have not sort of evolved quickly enough to sort of realize that there are some things that we need to have that knee-jerk, quick automatic response, and there are other things that really we don't need to do. And so, but based on that, the bias that we have actually has some function, but sometimes it goes and leads us astray. So unconscious bias, again, are having those mental associations when you're not really cognitively aware of it. You don't have any intention to do it. And really, there's not a whole lot of control when you see a certain thing and you automatically prejudge that particular activity. And oftentimes what we found is these unconscious biases often conflict with your own personal values. So if I ask you if you have a bias against individuals who wear hats inside the home, then you may say, no, of course not. I don't have that bias. But what we find is that if we do other tests and ask for these things, we can see it picked up. So it's not something you're aware of. It's not intentional. It may not be a value of yours, but it does show. So here are a couple of other examples of how this may play out in the healthcare system. So this is a research study that was published in 2012 where the investigators did a test with over close to 2,300 medical doctors and found that overall doctors showed a strong implicit bias or unconscious bias against people who were overweight or obese. So men who were providers, their bias was stronger than women providers, and the bias was strongest among those who were tested who were the thinnest. So if you were male and if you yourself was not overweight or obese, then that person was more likely to have a more negative bias towards someone who was overweight and obese. Another study looked at gender differences when it came to knee replacement. So 50% more men than women were recommended for knee replacement surgery, even when they presented with the same medical presentation. So again, something else beyond what is the medical presentation was factoring into the decisions by the providers to either recommend or not recommend knee replacement. And then this study, looking at some racial differences, took almost 300 internal medicine and emergency medicine residents, and they randomized them again to the same vignette, but it varied based on whether or not the patient was described as being black or white. Physicians reported that they didn't have any explicit or intentional preferences for white versus black patients. They also said that they didn't really think that there were any differences, and they didn't perceive that the patients would cooperate any differently. But the results from the implicit associations test reveal that implicit preferences favoring white Americans and implicit stereotypes of black Americans were less cooperative with medical procedures and less cooperative in general. So the implicit associations test, for those of you who are not familiar with it, it's been around for a number of years, actually started by a group out of Harvard. And it's a test that sort of tries to get at where you might have preferences for and against certain groups. I will make sure that that link is also included online for the recording. And so if you haven't done that test before, I think it's an interesting way for your own self-reflection to take a look at the test. So they have it based on various racial groups, religious groups, gender identity, and so forth. So again, just for your personal interest, it might be, I would encourage you to take a look and see. You might be surprised at your own personal results. So now that we have a general sense of unconscious bias and how it may show up, just a little bit more on background. So when we think about these biases, it's kind of like thinking about a pair of glasses with two different lenses. So on the left side here, for me, I see the blue side, which is the way I see the world, and then on the other side, the yellow would be the way you see the world. So we don't necessarily see the world in the same way, and that's because we come at it with very different lenses. So here I would just ask you to think, and you can kind of jot down for yourself, what kinds of things you might see here. So I'll give you a minute or two just to write that down. Okay, so for those of you who are thrill seekers and you love these, these roller coasters, you might have written down that you see fun, you see something that's exciting, you see something that's exhilarating. For the other group of you who might see this as, being the scariest thing ever, you might be seeing that it's scary, it's nauseating, and it's dangerous. And then the next question is, what is actually there? So some of you described this as really being fun and exciting. Others of you may have described it as being scary. But at the end of the day, when I ask you to look at this picture, what's really here is welded steel, it's bright paint, it's nuts and bolts, and it's a curved design. So we have basically, superimposed all these other feelings about this particular inanimate object based on the background and experiences that we've had. So if we had great experiences with roller coasters and other kinds of activities like this, then we're likely to bring those in if we had a great experience. But if we had a bad experience, we're likely to bring that in as well. So something for you to think about. So transitioning from an inanimate object to an animate object, the same thing here. What is there? What do you see here? So just like the roller coaster, what's in actuality you see here in this picture is someone with some longer hair, someone with some earrings in their ears, who wears glasses and has a fairly neutral expression. But when we ask, what would you see, or what do some people see, depending on your experience with someone who looks like this person in this picture, you might say, this person looks well-groomed, they look intelligent, they look expressive, and they're stoic. Again, if you had an alternate type of interaction with people that look like this person, then you might say, okay, this is one of those people. This person is socially inept, they're rebellious, they're unfriendly. Again, the picture did not change. There's nothing for you to adjust in terms of your screen. It's just that based on our experiences, we might see the same picture differently and come to some different conclusions. I also added this picture. This is actually a picture of a colleague of mine. And here, because it may be a little bit difficult for you to read the caption there, it's Dr. Tiffany Carson left, the caption says, UAB's Dr. Tiffany Carson left, discussed her study involving heart disease prevention in African American men. And then it attributes the author, the photographer there, and the news outlet. So what is here, if you look at the picture, is you see a research poster, you see two women talking, and you also see two women with paper or pad in their hands. And then the other part about, well, what do we see here? So in that caption, the person who was taking this picture and then the subsequent person who wrote the story indicates that it's Dr. Tiffany Carson who's on the left who's talking about her poster. In actuality, Dr. Carson is the faculty member who was talking to the other person in the picture about that person's their poster. And so one of the things that I think is important here is, why is it that the reporter got this wrong? And so it could have been that there may have been biases related to race that may have played into this. You have an African American woman talking about a topic that's about African Americans, and there may be some assumption that that could not have come from the person in that frame who was Caucasian or white. There may have been biases around age. The person, Dr. Carson looks to be younger than the person on the right, and so that may have played into the assessment about, one being a trainee versus a faculty member. Again, the topic that was chosen there might have been a reason why the reporter thought that was different. And there could have been something else. It could have been something that this person had. But what happened in actuality was that caption was not, in fact, what was actually there in that picture. So all of that is to say that the way we see the world is quite colored. So it's colored by our culture, which is one set of lens that we have in front of our eyes. It may be based on different kinds of groups that we belong to, and we all belong and have identifications with various different groups. So that's another layer that comes in front of our ability to see the world. There's also different individual characteristics and experiences that we might have that play a role there. And then there could be institutional ones as well, things that are part of our the workplaces that we're in and other kinds of institutions that we're a part of. So at the end of the day, we don't see things as clearly as night and day or as clearly as a picture. We actually see things distorted through all of these different lenses. And so this is a perfect way to sort of caption this. We see the world as we are rather than the way that it is. So let's talk a little bit more about the mechanics of this. So I mentioned before about how our brain has not quite evolved as much to sort of get away from our knee-jerk biases that exist. So we know that the greater part of our brain is the old brain, if you will. It's the fastest, the emotional brain, and that's where we have that automatic response of fight and flight. We also know that our frontal cortex, or the slow or thinking brain, is one that has evolved over time. And so what ends up happening is that you have some kind of stimuli that's coming in to our eyes and other parts that we perceive. And then it's kicking in with our initial response, which is typically that emotional brain type of response. And then it kind of works its way sometimes to the slow thinking. And so here's an example of how that works. So it's a little bit more difficult virtually, but here's a scan that some radiologists were presented with, and they were asked to look here for nodules that might be, basically reflective of cancer. And what they found was that a vast majority of people, in looking at this particular slide, fail to see, what I'm hoping at least some of you have seen already, is that there is a gorilla on the side of this slide. So many of them actually miss that totally, and it's not because they're not, well-trained, board-certified radiologists. One of the issues is that from the earlier whodunit video, it's selective attention. So when we specifically say, look for this scan to see if you see any signs of nodules related to cancer, then we are intentionally looking for something specific. We usually sort of weed out anything else that is not consistent with that initial instruction that we're given. So again, it's just a kind of a funny way to look at that, but they certainly found that a lot of people missed, sort of the obvious, if you will. So again, 83% of radiologists who were asked to search for the cancer nodules did not notice the gorilla at the top. So there's a lot of information that comes into us at any given time. So there's some estimates that over 11 million pieces of information are bombarding us in any given moment. Then there are certain things, even though that's out there, then we have to perceive some of that. Some of that then gets interpreted. Some of that then becomes our preference, and then we get to the selective attention. And at the end of the day, what we find is that, only about 40 to 50 pieces of information can actually be absorbed in that particular time. So there's a great deal that we're missing. Hopefully we're not missing gorillas in the middle of a scan, but there's a lot that we're missing. And based on that, there may be things that are happening in our encounters with patients that we're also missing. And so for those of you who had some kind of intro to psychology type class or lesson in school, you might remember this idea of Maslow's hierarchy. So Maslow, a psychologist, talked about the idea that we have a hierarchy, our basic needs around physiological needs and safety and belongingness, esteem, and self-actualization, kind of in this pyramid. What many of us have later found out, and other research suggests that Maslow may have had these different structures a little bit out of place, and it's actually belongingness more than our physical needs and our needs for safety that really drive most human beings. And this is reflected in this particular picture where you see, the lone guy, calf out there to himself. And what we found in some research is that being excluded from a group triggers activity in the same regions of the brain that are associated with physical pain. So for the vast majority of humans, we want to be together. We want to be thought of as a part of a group or part of a team. We really don't want to be different. We want to be together. And so how might that play itself out? It may play itself out by, the otherism. So the biases that we have may be related to us trying to make sure that we belong to a specific, oftentimes dominant group. And so here are some examples of all the different types of biases that people have. So hopefully by now you're sort of convinced, if not totally convinced, that we all have bias. Bias is not neither inherently good or bad. It is just that prejudgment. But there are all kinds of biases that we have that may then lead us to make uninformed decisions or make decisions that might negatively impact individuals that we're working with in the workplace or even in our patient encounters and care. So whether or not it's a bias towards height, so what we know is that the vast majority of CEOs and leaders of companies tend to be on the higher side, so more of an average around 6 feet tall. We also know that there are certain preferences and data around individuals who might be thinner weight versus overweight and hand dominance and so forth. So these biases exist. It's a matter of you doing your own self-reflection about which one of these are really that you can figure out for yourselves that you have, and more importantly, figure out how they may be negatively impacting your work. So the last part of this section is really about, how can you make that shift? How can you move from the knee-jerk, old brain kind of, I'm going to do this just because, in order to move into more of a conscious awareness and slow down so that you are able to track and see if those biases that exist may be negatively impacting your work. So we know that the road to unconscious bias is paved with good intentions. Again, we're gonna, take for granted that most of these things are not intentional, that people aren't saying, hey, I want to selectively give a different treatment to a particular group versus another. So it's not about your intentions, but it is about what actually is the outcome here. So the training here talks about 6 different ways that you can actually address your biases. So I already mentioned that I think it's important for you to do your self-reflection. So the implicit associations test is one that you can take and see if there are any clear biases along a number of different demographic characteristics, but also just sitting around and having some conversations and talking and thinking for yourself. So I think the first step in mitigating the bias is, like any kind of 12-step program, is recognizing and accepting that you have a problem. And so that problem is if you are having biases that's negatively impacting individuals that you work with and or your patients. So recognizing that it might exist is the first step there in mitigating it. Then the issue is you want to develop the capacity to use a flashlight on yourself. And this is just really thinking about, oftentimes it's really hard for many folks to sort of take a deep dive and do a critical assessment about what it is that you're doing that might be contributing to some outcomes that you don't want to have. So this is actually saying give yourself some grace there and think through what might be happening, what may be in your background and your experiences that have led to a particular bias that you have, and how might that be impacting others. The next way to address this is what's called practicing constructive uncertainty. And this is just a concept that's basically saying just be okay that you may not know what you don't know. So many of us, after lots of training or many years in a particular field, we feel like we know it all. And while we may know a whole lot, there are things that we just don't know. So this is a concept of being comfortable with and sitting with the fact that there may be things that you think you know that may be coming from an experience that you had many years ago that may not be in fact founded and grounded within truth or the actuality. So it's really thinking about what is actually here versus what you see. And so the idea of shifting from the fast brain to the slow brain is here in this particular quote that Rollo May is attributed to, which is freedom is the pause between stimulus and response. So if unconscious bias is this automatic response that happens, you get a stimulus that comes in and then you just respond, then mitigating that bias is to basically expand that length of time between you getting the information and you responding. And so one of the ways to do that is through a method called PAUSE, or P-A-U-S-E. So the P here stands for paying attention to what's actually happening, sort of beneath the judgments and the assessments. So something happens in your workspace or with a patient or out in the community, and rather than going immediately to saying, oh, that person's a jerk because they cut me off, or what is this person coming in, for the third time, they're not being compliant with my recommendations, to take a pause to see, well, what's really absolutely happening here. The A is acknowledging your own reactions and interpretations and judgments. So we're all going to have those responses, that emotional response, and it's okay to sort of take a step to say, well, I'm feeling anxious when someone, my friend walked me up to that roller coaster, or I'm feeling really nervous about going into the boardroom and having the conversation with my boss. So just, taking a step to recognize what those feelings are, and then take a step also, what are those judgments? So why was I so quick to say that this person was a jerk because they moved into my lane at a very fast pace in a distance that I didn't think was safe? The U is to understand the other possible reactions, interpretations, and judgments that may be possible. So there may have been a different reaction that you could have had. So rather than being angry or upset, or being anxious at the roller coaster, that could have been a different reaction. So you could think about, well, wow, there could have been many things that are happening to this person as you're making your judgment. So maybe they were really late, or they had to get somewhere. They misjudged the distance between my car and their car, or various other things that you can stop and think about. There's usually more than one ways that you might interpret the same situation, just like we showed in the different pictures before. The S is to search for the most empowering, productive way to deal with the situation. And this is particularly when you're in relationships with other people. So workplace, you have coworkers or patients or other folks that you're seeing in the community. These are relationships that hopefully you want to cultivate and you want a positive outcome for. So you want to find a response that is going to be respectful and valuing of perhaps a difference of opinion or perhaps a different perception about what's going on. So you want to take that time to search for what is the best possible way for me to respond. It may not be shouting, it may not be slamming the door in someone's face or walking away. The most empowering way may be just simply saying, hey, I don't understand, what happened here. Can we sit and talk? And then the E is to execute your plan. So at the end of the day, as you're pausing, as you're going through these different steps, ultimately you've got to come up with a reasonable plan that is empowering, that leaves yourself open to that uncertainty, and then you've got to follow through with that plan as well. So the next step there is just exploring awkwardness and discomfort. So as you're doing the work to try to mitigate your own biases, it is going to be challenging. You're going to start challenging beliefs that you might have had for decades, things that you may have learned as a child or you may have learned in school, things of that nature, and that's challenging. You may actually start saying some things that people looking at, that's really weird. Why are you asking me about this? But I think it's important to stay with that discomfort. We get growth and we move through these issues when you're able to sit with that discomfort, get the feedback, and then work on it over time. And then I think this is the last one in terms of the mitigating biases, and this is engaging with people you consider quote unquote others, and expose yourself to positive role models in that group. And what this means is really looking around. So who are the people, who are your trusted go-to folks to give you feedback? And if they tend to be mostly like you, so whether or not that's around race or gender or education, socioeconomic status, any of those different ways that we check our boxes demographically, then I think this is an idea of trying to expand that circle of trust, if you will, to identify other people that are not your usual go-to folks so that you can start to receive additional feedback here. You also want to think about if you identify that you have particular biases towards a particular group, then you want to see, well, who is someone who is counter to that bias, and how can I have more direct conversation, communication with that individual? And this is really key because it's really difficult when you have a personal relationship with one of that background to then revert back to your stereotypes because you're thinking, okay, well, I know John, and even though John is a member of this group, John doesn't act like that, so it gives you a little bit more cognitive dissonance, if you will. Start your brain thinking a little bit more, and that has been shown to help to mitigate bias as well. And I think, I misspoke. So this is the last one. So getting feedback. It's really important that you are getting that feedback. If you do develop that circle of trust with very diverse groups of folks around you, then asking them, how are you doing it? How are you doing with this mitigating your bias? Be open to telling people that you're working on this, that you have a bias in this area and you're working on it. Give people permission to tell you how you're doing, and then also be open if they say, well, you don't quite have it so right, or you made this statement in this meeting, or you said this, or you wrote this in your note, and be open to that and receptive to that feedback. Again, it's in the spirit of being able to grow and move forward and help to mitigate those biases. So it's the combination of those 6 things that through the Cook-Ross training, we really think are shown to be evidence-based to kind of move you away from those biases that have negative implications in your workplace as well as in your patient care. So thinking about all those different things in those circles will certainly put you on the right road to address these issues. And so the last part of the training is really about what are you committed to doing. So I mentioned before that a lot of the research has said, raising awareness can help to lead towards mitigating unconscious bias. But that only happens if you are being intentional. It only happens if you are continuously working on it. And so here are some things for you to think on your own about what you might be willing to plan and what actions are you willing to take in your particular situation. So based on what we've talked about today, I would encourage you to identify concrete action steps. And here are just a couple of ways that you can think about this. So one area would be, how would you use this information to improve your relationship with a colleague? So is there someone that you think there's some kind of a tension, or you think things could be improved, and there might be something going on in terms of biases that you have that might be prohibiting that relationship from being better than it is right now? And so what could you do in that case? Another idea is to identify an important decision-making point that you have coming up, and then strategize how you can mitigate the impact of bias in that decision making. So, thinking about this issue, and instead of going about deciding the same way that you've always made that decision, take a step back and see, well, are there biases in that decision making? And if they are there, then, what could you do to help reduce that? Could you bring in additional people with different backgrounds and perspectives that might help you to get to a different decision that may actually be one that is better received or well received by all? And then the last idea in terms of making concrete action steps is, perhaps coming up with an idea for recognizing, navigating, and or mitigating biases in your team, your department, or your organization. So many of us are leaders, either in the large L sense, in that we've got a title that gives us a leadership role, or we may just simply have leadership qualities about our personality. Regardless of that, if there's a group that you're a part of and you think that biases are negatively impacting the group and the group's productivity, then think about what are some of the ideas that you could do to help to reduce that bias. So with that, that's the formal unconscious bias training, and that's what I was prepared to go over with you a few months ago before we had our current pandemic. And so what I thought I would do just in the last few minutes is just highlight a couple of places where bias is clearly creeping up into our current navigation of the coronavirus pandemic. So I just highlighted a couple of snapshots from recent articles that have been in the lay press as well as in some of our academic journals. So the top one there is, the coronavirus is amplifying the bias already embedded in our social fabric. So I'm sure by now you're aware that what we're finding out about the virus is that there are certain groups and populations that are more negatively impacted by COVID-19 than others. And certainly when we look at the death rates and the death toll around COVID-19, we see that racial and ethnic minorities, individuals from rural areas, and lower income individuals by far have a higher rate of death from COVID-19 relative to their other counterparts. And so this NPR story, talks about, again, the idea that the coronavirus does not discriminate, but our U.S. healthcare is showing familiar biases. So we see that, again, noted health disparities from earlier in the presentation, where we see some of them are more likely to be among Black or African American populations, lower income populations, and so forth. Those things are actually playing themselves out right now with the coronavirus pandemic. We also see some other types of issues that are looming, especially with the potentially second pandemic that's going on right now, which is a greater awareness around racism and the implications of racism. So we've seen other headlines about Again, how this is specifically targeting or having negative impacts on Black Americans. The Boston Globe piece here says why I don't feel safe wearing a mask. So certainly we hope that all of you are practicing good public health recommendations and social distancing and wearing masks and so forth. But for a group of us, myself included in terms of African Americans, that might be quite dangerous depending on what people see or are not able to see in terms of facial features that might lend individuals to be at greater risk there. Another area that came out fairly early in the pandemic was this issue around bias around ability or disability. Some of the earlier conversations around limited ventilators and what our guidelines were in terms of prioritizing ventilators for those who were having severe respiratory distress as related to COVID-19 really identified a bias towards individuals who negatively impacted individuals who were disabled, and so that was brought out. And so one of the articles here is talking about how negatively impacted individuals who have a disability might be if in fact they might need to use a ventilator if their COVID-19 or coronavirus progressed into a situation where they needed that. So again, highlighting some of the issues between the two pandemics, the racism, the biases, and racism and biases, as well as the coronavirus there. And then the other thing that has come up related to bias is the stigma that was related to COVID-19. This is a set of steps that was suggested by the American Psychological Association, specifically earlier on when there were a number of individuals that were spreading an idea that this was a virus that was deliberately or intentionally created in Asian cultures, and then it came over to the U.S. And so, these are 7 steps around mitigating those types of biases. So the first one is making sure that we're all spreading facts and not fiction and myths, that we're engaged in our social influence, and making sure that those facts are being permeated through all of our social networks. The other strategy they had was amplifying the voices of people with lived experience, especially with coronavirus. So it's really important to make sure that their thoughts and their ideas and their experiences are speaking as loudly as other individuals in this space. Earlier on, I think it was really important to make sure that all the faces that we saw, the literal faces and the images, that they were more diverse, to really show the public that this is not just a one-side kind of condition or disorder. So portraying different ethnic groups in public information and materials was really critical, especially because we know that certain groups were lagged behind in terms of doing some of the public health recommendations to spread the sort of stop the spread of the coronavirus. A fifth strategy they talked about was promoting ethical journalism, so making sure that things that are being published, especially by journalists, are free from bias, that information is being shared, and that to the extent possible that there's not bias in that reporting. The sixth strategy is correcting myths and rumors and stereotypes, and making sure that our own language is not including that information going forward. And lastly, they recommended, for all of us to challenge those whose language promotes bias. So again, some really practical steps there as we're addressing some of the bias and stigma that's related to COVID-19. So with that, really come to a close with the presentation. I kind of leave with this, funny cartoon, just hoping that one of your bias, your confirmation bias, is still intact here, and hope that you found something useful about the presentation today, and we'll go ahead and do some of your own self-reflection. I'll end with just one reminder. So if there are any questions as it relates to the presentation today, please use the website to email Lisa Davis with your questions. I would be delighted to provide responses to those questions, and then she will make sure that those get back out to you. But certainly appreciate your time and effort today and your attention. Wish all of you good health and to stay well and continue to practice your social distancing and helping to reduce the spread of COVID-19. Thank you.